Welcome back to another session in laboratory medicine. The next 10 or 15 minutes we're going to be talking about the laboratory diagnosis of dyslipidemia. And so why do we care about this? We care about this because dyslipidemia leads to cardiovascular disease. This is why we use statins, billions of dollars a year in drug therapy. And I'm going to review quickly the sources of lipids and how we measure them and some of the interpretations. So lipids can become in circulation from eating, so that's the exogenous pathway. And in your gut, in your intestines, you package it with, using the Golgi, you add apolipoprotein, so that would be apolipoprotein B48 and apolipoprotein A. You combine that with cholesterol esters, triglycerides, and phospholipids, and you absorb that as a chylomicron. Interesting story, when I was in graduate school, I was a poor grad student, and they did drug studies. And so to get into the drug studies, you had to get blood drawn and show that you were healthy. I thought I was a really healthy young person. I went in for this drug study. It was going to pay $1,500, so it would double my salary for the month. So I was excited about being in it, and I get my blood drawn, and the next day they say, "Sorry, you're not qualified." I was like, "What?" I was like, "I'm perfectly healthy. Why? How can you reject me?" And they said, "Well, your chylomicrons were through the roof, And I was like, "Wow, how is that possible?" And then I thought about it. It was right after lunch that I went in to donate blood for this drug study, and I'd eaten an Italian hoagie in one of these little Italian sandwich shops in Richmond, Virginia, that made these killer subs. The grease just sort of ran down your elbows as you chomped it down, and lo and behold, that shows up when you do blood testing. So I now know that if you want to do lipids, you have to be fasting to do your LDL. So a chylomicron is a triglyceride rich, so that's the mayonnaise and the oil from that sub that's been packaged into this particle. It has a half-life of 10, 15 minutes, something like that. It's a fairly short half-life. It has two lipoproteins, one A and B. It interacts with HDL, and we know that HDL, we call that the good cholesterol. And why is that the good cholesterol? It's the good cholesterol because it donates a couple of apolipoproteins that are important. It gives it apolipoprotein E, which is going to be important, and it also gives it apolipoprotein C. And in particular, apolipoprotein C2 is important because it activates in the periphery LPL, lipoprotein lipase. And what does that do? That cleaves triglycerides into free fatty acids, which become an energy source, and it decreases the triglyceride content of chylomicrons. When chylomicrons have apolipoprotein E, they already had the B, and they have lost some of their triglyceride component, they can be taken up into the hepatic cells, and the cholesterol esters can be used for whatever's necessary. So that's a quick summary of the exogenous pathway, and that's why what you eat, a hoagie for lunch, shows up in your bloodstream, and why it's important to collect certain labs fasting. On the endogenous side, so not only what you eat, but your liver is also producing lipoproteins, and it produces VLDL. It has a half-life of maybe an hour, something like that, 50 minutes. It's about 50% triglyceride, about 50% cholesterol esters. It already has apolipoprotein C2, so it interacts in the periphery, delivering free fatty acids as an energy source, reducing the triglyceride content. It also interacts, after it's lost some of its triglyceride content, it's now an intermediate density lipoprotein, or IDL. It interacts with HDL again and reduces the triglyceride content further to form what we know as LDL. And LDL is really the primary drug therapy, particularly for statins, is reducing your LDL content. LDL has an apolipoprotein B, and it is taken up at the liver by the B100 receptor and is catabolized. The problem is if you have too much LDL, you saturate this receptor and macrophages start to eat the LDL. They form foam cells, and that's the beginning of a plaque in the inflammatory process that leads to cardiovascular disease. And so really our target is reducing LDL in many of the therapies. How do we, in the laboratory, assess hyperlipidemia? Total cholesterol and HDL you can measure either fasting or not fasting. It doesn't really have a big effect on total cholesterol or HDL cholesterol. That would be high density lipoprotein, so HDL cholesterol. However, if you want to measure triglycerides and LDL, which are the common components of a lipid panel, then you need to be fasting. So LDL and triglycerides, you need to be fasting. Total cholesterol and HDL, you don't need to be fasting. Typically, we don't actually measure LDL. Initially, it was hard to measure LDL. In all of these situations, we're measuring cholesterol, and it was difficult to differentiate LDL from IDL and from HDL, and so we came up with a calculation. And so this is known as the Fitzgerald equation, and it's total cholesterol minus HDL minus the triglycerides divided by 5. And so this is essentially a representation of the intermediate density lipoproteins. And we like this because it's free and it's also reasonably easy. So this equation is valid as long as the patient is fasting and as long as their triglycerides are less than 400. And so all of the drug studies pretty much use calculated LDL, and that's why we continue to use that. If you're not fasting, if your triglycerides are greater than 400, we do now have specific techniques that we can measure a direct LDL, and that's what we do. Another lab test or another lab value that's calculated is the non-HDL cholesterol, and we like this test because it is a good indicator of cardiovascular risk, and you don't have to be fasting, and it's simply total cholesterol minus HDL cholesterol. And as we said, fasting is not required. If you think about reference ranges for non-HDL cholesterol, they're about 30 milligrams per deciliter higher than LDL cholesterol. Risk factors, and so for a long time, and still some practitioners today adjust their reference range for LDL depending on risk factors of the patient, and that sort of makes sense. So risk factors for modifying LDL really are things your mom told you to avoid. So hypertension, cigarette smoking, those things, if you do those, if you're older, then your target for LDL is going to be lower. And so these are what we know as the risk-related reference ranges for LDL. And so LDL goals in milligrams per deciliter. If you have 0 to 1 risk factor, an LDL of less than 160 was considered appropriate. However, if you had 2 risk factors, you smoked cigarettes and you were older, then your LDL should be at less than 130. If you had cardiovascular disease or equivalence, and equivalence there means diabetes, then your LDL target range was less than 100. If you had a recent MI, you were at very high risk, so they want your LDL to be less than 70. And extreme risk, that's people that aren't responding, that have had a recent MI, then they really are targeting low LDL concentrations. In addition to drug therapy, things that physicians tell their patients to do are therapeutic lifestyle changes. And what does that mean? These are things your mom told you to do. Things like get exercise, eat appropriately, lose weight, things like that are part of the lifestyle changes. And typically, if someone has a low risk for cardiovascular disease, that's going to be the first thing that they recommend. And if they're not successful in lowering their LDLs with therapeutic lifestyle changes, then they put them on statins or some other drug therapy. So in 2013, the American College of Cardiology and the American Heart Association actually changed the guidance, and they sort of are going away from the risk-related target ranges for LDL, and really only basing it on randomized clinical controls, RCTs, randomized clinical trials that have outcomes associated with it. And basically, as I said, they don't have specific goals for LDL. They look at a 10-year risk, and based on the 10-year risk, they are recommending either low, medium, or high intensity statin therapy. So someone who has cardiovascular disease, atherosclerotic cardiovascular disease, then they get put on moderate or high dose statin therapy, and we'll talk about what that means in a second. If your LDL is greater than 190, then that's obviously high, and they want you to be put on high statin therapies. If you're diabetics and you're in between that 70 and 189 range, you should have moderate statin therapy. And so really statin therapy depends on risk and LDL concentrations. So high-intensity statin therapy basically lowers a patient's LDL by 50%. So it doesn't really matter if you're at 150 or if you're at 200. We want to reduce that by 50%. And in randomized clinical trials, that showed good outcomes. So that was as efficacious as getting, as treating to, a specific range. So moderate therapy is between 30 and 50%, and low-intensity therapy is somewhere around less than 30%, but a clear reduction in LDL. So that's a quick review of dyslipidemia and laboratory diagnosis. If you want to measure lipids in patients, they have to be fasting in order to interpret an LDL or a triglyceride, i.e. don't eat a sub and then go get your labs strong. Whereas HDL and total cholesterol, you don't need to be fasting. Thanks for tuning in.